Hi, I'm Alex with PCRI, and I'm here with our Executive Director, Dr. Mark Scholz. I'm representing the PCRI Helpline today, and we are here to ask your questions to a full-time prostate oncologist. So I'm really enthusiastic about being here. It's an honor to be able to ask your questions to an expert, and we'll get right into it. How are you doing today?
I'm doing great.
Are you ready to start an entire new YouTube series based on all prostate cancer questions 24/7?
Well, I answer questions all day long, so this is fun. Most of the time it's with elderly people, usually males, but...
You just have to pretend I'm like a 70-year-old average male coming into your office. Don't I look like it? I think I can try to pull it off.
I do have to pretend that because I presume the people that are listening to us are of that genre.
Yeah, I think so. So our first question is about Casodex, and these questions actually came from the search engines on our website, so we know that people have been looking up Casodex on our website, and this question particularly caught my eye because I like the way the person asked it. It was Casodex, why is it added to everything? So basically he's asking, why is like my brother and my third cousin twice removed on Casodex too? Like it's everywhere.
Well, Casodex was one of the first medicines that was FDA approved to help men with prostate cancer. It's a pill once a day, very well tolerated. It doesn't usually cause much of any side effects if people are already on Lupron. And when they're talking about adding Casodex, they're usually talking about adding it to Lupron or a Lupron-like drug. So the early trials showed that men that took Casodex in addition to Lupron lived longer. Now, it wasn't a big difference in survival, but it was a difference. And the only reason it just didn't become a universal for Lupron forever was that it was really pricey when it was first approved. But now it's generic, it's very accessible. And so it still is the policy to give Casodex for at least a month when people are starting on Lupron. Lupron can cause a temporary rise in testosterone, which is considered undesirable, obviously, for men with prostate cancer. So by being on the Casodex during that flare period, they are protected from the rise in testosterone. Now, some have then recommended stopping the Casodex, and the original decision to stop it after a month or so was to save money. So my policy is usually, yes, leave them on the Casodex as long as they're on the Lupron, and the additional anti-cancer efficacy added to the Lupron is useful, and it doesn't usually cause any additional side effects.
So, for instance, when I Google Casodex, it comes up as a hormone treatment and it comes up as a chemotherapy treatment. Can you explain to the audience why that is?
Yeah, the idea of Casodex as chemotherapy is more of a billing issue. The way that Medicare coded Lupron and Casodex early on was as chemotherapy, and that was just because it's a medicine to treat prostate cancer. But when we think of chemotherapy, we're thinking of injectable medicines that can cause hair loss, that can cause nausea, and so the idea of it being a chemo is actually ridiculous. But yes, that's a carryover from some goofy billing issues, and sometimes you'll still see that. They're calling it a type of chemotherapy, which in reality is nothing of the sort.
Okay, and another thing, when I was researching Casodex, I saw the side effects of Casodex, and some things it mentioned were like bone and pelvic pain. Why would Casodex cause that? Is that accurate?
Well, usually the side effects of Casodex are very close to what Lupron causes, only typically milder. And I'm talking about using Casodex in conjunction with Lupron, not Casodex as a single agent. We can talk about that separately. But when it's used in conjunction with Lupron, there may be a slight increase in fatigue. Men do need to be monitored for rare problems with their liver, and this is tested with a blood test about 4 to 6 weeks after someone starts on the Casodex.
What type of blood test is it? I mean, what's the name?
Yeah, the blood test is called a hepatic panel. And so typically after someone begins hormone therapy, they'll come back to the doctor's office after 4 to 6 weeks, and they'll be tested for any liver abnormalities with a hepatic panel. And they'll also have another PSA to make sure the treatment's working, perhaps check a testosterone level to make sure that the testosterone is lowered as would be expected from the Lupron component of the treatment. And those tests usually are very routine and we rarely see problems. But there's a rare case, maybe 1% of people, the Casodex can create some irritation of the liver. You'll see that with elevations of two blood tests called AST and ALT. And then the Casodex needs to be stopped and it will reverse. And so, because you're picking it up in a timely fashion. If the Casodex was continued without monitoring and in those rare patients that have problems, it could become dangerous. The other thing to mention with Casodex, because sometimes Casodex is used by itself as a standalone treatment because it's milder than Lupron. And it's very convenient, it's a pill, it reverses much more quickly than Lupron. But one thing that happens, since testosterone is not completely eradicated, all that testosterone can be converted into estrogen, which translates into breast tenderness and breast enlargement. So men that are taking Casodex by itself need to take some sort of preventative measures, either do radiation to the nipples prior to treatment or take an aromatase inhibitor such as Femara or Arimidex, and that stops the conversion of testosterone into estrogen.
Gotcha. So our next question is, what is SpaceOar? I think there's a lot of marketing going around what SpaceOar is, and a lot of patients have questions. And not only what is it, but the patients who know what it is, how do I get it? So
SpaceOar is a very clever new technology. They can inject a gel substance between the rectum and the prostate and push the rectal wall as much as a half an inch away from the prostate. And this is a really wonderful thing because historically the radiation therapists were obligated to treat a portion of the rectum because it was right on the edge of the prostate. And a small percentage of people would get burns there from the radiation, and in some cases it would never heal. This is called radiation proctitis, and it can be disastrous. So skillful doctors over the years have really learned to minimize radiation proctitis, but as you know, not all doctors are equally skilled, and so SpaceOar is a nice way to kind of take out an insurance program against getting a rectal burn. It's administered through an injection through the perineum, so it's a little uncomfortable when it's put in.
do they numb it?
Yeah, they numb it up, and there is a skill factor in putting spacer in. You probably want to look for a doctor that's done a number of them. Many times the radiation therapists themselves know how to put the spacers in, or they may refer to a urologist that they work closely with, and he would put the gel in a week or two prior to doing the radiation treatment. The beauty of the technology is that after about 90 days, the gel just absorbs and turns into water and disappears. So the radiation therapy now is given over anywhere from a 2-week to a 9-week period, so that allows plenty of time for that distance to remain, and then after the radiation's finished and it's no longer needed, it spontaneously regresses.
Got it. So when it devolves, like, how does it go out of your body? Just normal?
So it turns into water, and then the previous little cushion or pillow of gel that was there just disappears.
Oh, that's cool.
Yeah.
That's really cool. And it's just two type of gel compounds they mix together, and it takes about 20 minutes to do the procedure?
Yeah, if it's done adroitly and skillfully, it could be done in 20 minutes. I've seen a few of these done. I mean, the men are up in Trendelenburg. A few women out there remember pelvic exams. It's very personal and intimate when you have a SpaceOar put in. The needle goes between the scrotum and the anus. So the guy's sitting there with his legs up, and then the needle goes in, and they have an ultrasound in the rectum so they can see where they're going. And then the actual injection is done very quickly, and probably just like 5 seconds. They just push it right in, and then it's all ready to go.
Right.
So the beauty of it is that this very frightening and potentially debilitating proctitis problem has been pretty much circumvented, and I recommend it pretty much routinely, even with the best doctors. It's just an extra layer of insurance to make sure that terrible side effect doesn't occur.
Yeah, I think definitely with just working at PCRI and being on the helpline, when we get calls from people who have radiation burns, it's just heartbreaking. And having to deal with the side effects of that and dealing with all that I'm a huge fan of SpaceOar.
Yeah.
And I've talked to a lot of people that have had it, and they said it was a pretty easy procedure. I had one guy that was like, well, I had a biopsy in the same place, so it's kind of like one needle. It's not that bad in comparison.
Yeah.
So I thought that was a really good way to look at it. But I think one of the biggest questions we get is, so does any of these doctors put it in, and where do I find someone? How do I ask? Do I just call the office? I know that SpaceOar.com has a finder and a locator that they can see. It's right on the front page of their website. Is there anything you tell your patients in particular?
Well, I think if you're selecting the radiation therapist carefully, the really quality doctors out there are going to be familiar with it already, and they will have a plan in place. It's been out long enough now, and it's quite revolutionary. So if you run into a doctor doing radiation that hasn't heard of SpaceOar, maybe you better be looking for a different doctor.
Got it.
Yeah.
And it's covered by Medicare and other insurances pretty well. So
Yes.
to me, it's a very safe bet of what we should
Yes,
be doing.
and I mean, talking about that issue with people with proctitis on the helpline, I mean, there really isn't an effective treatment. They talk about doing hyperbaric oxygen, as that may help a little bit, but it's mostly just keeping your fingers crossed and just hoping and praying that it'll go away, and it doesn't always go away. Sometimes it remains for the remainder of that individual's life. So we're talking about an incredibly sensitive area of the body
Right.
being damaged, and so it's a wonderful new technology.
The next question we had is, how does someone interpret their biopsy report? And I think they get these numbers when they're newly diagnosed. They don't know what to do. There's like a plus sign in the middle of it. Does that mean it's better or worse? So what does all that mean?
So that's a big question. We could probably do a few videos on that. But the main things that I look at when I look at a biopsy report, which is reporting out a random biopsy, usually people have had 12 separate sticks in their prostate. And if it's a well-performed biopsy, the doctor labeled where in the gland each stick came from. I still come across reports where they just throw all the cores, the removed cores into a bottle, and they don't say where they came from. It's tragic, because the information about the location of the cancer in the prostate is very useful, especially if someone's thinking about doing focal therapy, if you want to just treat a section of the prostate to try and reduce your risk of erectile dysfunction and other side effects. So we always look at how many cores have cancer in them out of the 12. We look at if there's, say, a couple cores involved, let's say 2 of the cores have cancer. We look at how much of the cancer within the core has cancer, because when they stick the needle in, it doesn't mean that it's going to hit 100% cancer. It may hit the edge of a tumor, or it may hit the center of a small tumor. And so each core, which can be 3/4 of an inch long, for example, may have 1/4 of an inch of cancer and 1/2 an inch of normal prostate tissue. So we look at the number of cores involved, we look at the percentage of involvement of the involved cores. And so you're already starting to get a sense of how big this tumor is.
Right.
The number of cores plus the percentage, is this a tiny tumor? Is this a big tumor? Obviously that's important. So that's important information from the biopsy report. The other thing, of course, is the grade. You're talking about the plus and the minus. And the problem with prostate cancer, unlike say skin cancer, is we used a number system instead of giving different names to the different types of cancers. In skin cancer, we have basal cell carcinoma, which would be probably like a grade 6 prostate cancer. And then we have the melanomas, which maybe would be like a grade 10 prostate cancer. So people think that there's sort of a smooth continuum, but really these different numbers are identifying different types of prostate cancer. And as the number goes up, the potential for spread, the potential for growing more quickly, and the potential for being resistant to treatment all go up as the number goes up. So the number, how many of the cores have cancer in them, what percentage of core involvement, and then, as we already mentioned, the location in the gland. There's a ton of information, useful information, that comes from these biopsies, and this is what people look at first. They also look, of course, at how high is the PSA, and in rare circumstances, they're looking, is there cancer spread, with scans, outside the body. Those are incredibly important factors. But for most men being diagnosed with PSAs less than 10 to 15, the cancer is going to be in the prostate, and the big question is, what grade is it, and how big is it?
Right, right. So how often, I mean, as far as the accuracy goes of these biopsies and the reading, like, do you suggest that people go get second opinions and get a secondary reading on these biopsies?
For the most part, yes. The assignment of a grade is a skill, and certain doctors do it more and they're better at it. The distinction between prostate tissue, like a normal core biopsy, and cancer, I haven't seen that mistake made. I mean, the doctors that are reading these, they can tell the difference between prostate gland and cancer. But the assignment of an accurate grade can vary, even amongst experts. So one way to cross-check the validity of a grade is with some of these new genetic tests, like Prolaris, Oncotype, and Decipher. So that's another independent way to look at how aggressive the cancer might be. And that's how we decide what kind of treatment to use, how aggressive the treatment should be. If it's a more aggressive cancer, more aggressive treatment. If it's a less aggressive cancer, milder treatment.
So being the prostate expert that you are, being in the field forever, you know who the expert guy is that should look at these biopsies for a second opinion, and that's Jonathan Epstein, right?
We've been sending work, there's a number of good pathologists out there. Dr. Epstein has made it a very convenient way to just have your biopsy slides sent to Johns Hopkins, get them reviewed, and of course you're dealing with top-level pathologists. He's certainly not the only good pathologist in the world, but he's made it very easy to get cross-checked, and he's got an excellent reputation as being one of the preeminent prostate pathologists in the world.
Right. So once a person gets that number, so maybe it's 4 + 3 = 7, and then they're in, the teal stage, what should they do with that? Like, I know PCRI has, a lot of resources on our website, so what can they do with that number to help contextualize their place in prostate cancer?
Well, I'd recommend that they use your resources to find out, for example, if they're a grade 7, we divide men into low, basic, and high categories based on how high their PSA is, how many biopsy cores, because the treatment is going to vary even within, we call it teal, other people call it intermediate risk, and you can go anywhere from a very favorable low teal that someone could do active surveillance, just watch it, versus unfavorable intermediate risk, what we call high teal, where someone should be treated with a combination of hormones for 4 months, a seed implant, and IMRT, all in combination. So the teal category varies so greatly. A big part of that is the biopsy. Is it a 4 + 3? Is it a lot of cores involved? And that information is on your website.
Right. And you can take the prostate cancer staging quiz. So if you go to PCRI.org, there's a big take the quiz button, and you can put your PSA information, your Gleason score, and it's just 6 simple questions, and it'll identify you in the whole context of where prostate cancer is. It'll identify you in what stage you're in, and then once your stage is identified, you can now be presented with information on the basics of prostate cancer, the treatments available specific to your stage, the side effects, and then any lifestyle issues that help build out a full picture of where you're at and options that really are important for you to know. And so thank you so much, Dr. Scholz. I really enjoyed this. I learned a lot. I'm very excited about this series because I get to get all of my questions answered. And it's an honor to be able to represent the Helpline and PCRI as we go into this. So thank you.
Thank you.
Go ahead and subscribe to our YouTube channel. The subscribe button is right here on the bottom right of this video, and give us a thumbs up if you like the content. One of the big things that PCRI is super passionate about is we want to answer your questions. So go ahead and leave your questions that you would like Dr. Scholz to answer in future videos in the comments below, and you guys can go ahead and have conversations. If there's more information, you're like, oh, I like that person's question, we should add this, and we're gonna go ahead and our team's gonna read through that. And you'll see it in future videos. And we're here, we're excited, and we love you at PCRI. We hope you have a great week.